So today we get to learn the overview about CalAIM and the referral process. You get to hear from multiple providers enhanced care about the referral process for enhanced care management, housing related community support programs, and hopefully at the end of this orientation, you'll have a better understanding about the process, timelines, and best next steps. I will be turning over the presentation to Naomi Del Rio. She will introduce herself, as will all our presenters today. Thank you again for being here, and feel free to use the emojis and a reminder to use the Q&A.
Yeah, good morning, everyone. Thank you for the introduction and for getting us started, Jody. I am Naomi Del Rio, Administrative Analyst at Sacramento Steps Forward, and I'm so happy to be here today alongside our Managed Care Plan and Transform Health partners to share some information about CalAIM in hopes that what we provide today can be useful for you all to help those who you serve. We do have a pretty packed agenda today, so we are currently in the introduction, and I'm going to go ahead and provide a CalAIM overview, diving more extensively into the enhanced care management, community supports, and community health worker benefits. I am then going to pass it over to our Transform Health partners for some policy updates, and we will then pass it over to our managed care plans to share on their respective referral processes. We are fortunate in Sacramento to have a joint referral workflow from a referral form that our managed care plans have worked on. So our Transform Health partners will share a little bit more on that later, and then we will open it up for a Q&A, and that'll wrap up our time here. So next slide, please. All right, so I have introduced myself and touched on who else will be presenting today. But we would also like to know who else is here. So if you could all please grab your phones and open the camera app and scan this QR code, we will get a live poll going. And Jody, you can go on to the next slide, please. Awesome. Thank you. I see you all already beginning to submit your answers. So, we can go ahead and select Start Menti. Thank you. Yeah, so you can still unscan the QR code on the side if you're needing to join. But yeah, just first question, wanting to know what is your role? I recognize many of you actively flex between all of these roles. So if you could just please select the one that feels most appropriate. And there is a 30-second timer if we could just get that on the screen, please, for a visual cue. All right, no worries.
The timer's not working.
No worries, Jody.
Naomi, I'll be our timer.
All right. I see we have 108 out of 120. I think that's pretty good. See, we have a lot of case managers here today, a lot of system admin and leadership. Thank you all for being here. And for the sake of time, we're going to go on to the next question. All right. And I see a lot of you have already answered, but this next question is, do you currently serve Medi-Cal members experiencing or at risk of homelessness? And no worries if you're not sure, if it helps you feel any better, these answers are anonymous. Either way, we're happy to have you here, but glad to see that a lot of you do serve Medi-Cal members. This information is tailored to you for that. All right, awesome. And if we could please go on to the next slide, please. My favorite one. How much do you know about CalAIM? And I see we have a lot who know a little bit. Seeing that a lot jumping up. That's nice to know. All right. I think we're pretty good. So thank you all for joining and thank you all for sharing, even those who have maybe who feel they have no knowledge on CalAIM, maybe CalAIM just the term is all you know. We're really the purpose of today is to try and get us all on the same like baseline level of knowledge. So thank you all for participating. Very helpful for us all to know who is also here to know how we can move forward in future opportunities for you all. So now we're going to get right into it and we're going to begin with some terminology. And friendly reminder, if you have any questions throughout, please drop them in the Q&A and we will try to get to them throughout. So next slide, please. The first thing we want to state is that Sacramento Steps Forward is not a direct provider of CalAIM services, but we do have a role as a system lead to help you better understand what CalAIM is, support the building and scaling up of CalAIM services in our community, and troubleshoot gaps and opportunities to integrate CalAIM into our homeless response system through coordinated access. And next slide, please. So we don't have enough acronyms in the homeless response system. So CalAIM stands for California Advancing and Innovating Medi-Cal. It is a long-term commitment to transform Medi-Cal toward equitable, coordinated, and person-centered care. It is an initiative of the Department of Healthcare Services, or DHCS, to improve the quality of life and health outcomes of Medi-Cal members by implementing delivery system, program, and payment reforms across the Medi-Cal program. It emphasizes a population health approach, which prioritizes prevention, addresses social determinants of health, and transforms services for communities who historically have been under-resourced in the healthcare system. It is intended to provide access to new and improved services for holistic care that addresses all physical and mental health needs. As part of this vision, CalAIM is an integral component in solving homelessness through bridging the housing and healthcare systems. So to sum it up, CalAIM is intended to integrate medical care, behavioral care, and social services through initiatives like enhanced care management, community supports, and the community health worker benefit, which we will get into today. But there are other initiatives that contribute to this goal, such as the Justice Involved Reentry Initiative, which focuses on improving healthcare access and continuity of care for people who are incarcerated and transitioning back into the community. Next slide, please. All right. One of the cornerstones of CalAIM is population health management, which establishes a cohesive statewide approach to ensure Medi-Cal members' individual needs and preferences are being met. So from the bottom up, we have basic population health management, which is essentially all of the programs and services available to all managed care plan members. And then we have complex care management, which is for members at a bit of a higher but medium risk, where there is a bit more coordination of care. And at the top, we have enhanced care management, which is for members who have the highest needs and need more intensive coordination of care. And the last thing to note here is that there are also transitional care services available for Medi-Cal managed care plan members, transferring from one setting or level of care to another. Next slide, please. All right, so we're going to dive into Enhanced Care Management, or ECM, which is a statewide benefit for Medi-Cal members with complex medical needs. Through ECM, lead care managers provide intense case caring support and coordinate the members' physical care, mental care, dental care, and social services, meaning the members' clinical and non-clinical needs are being met. So recognizing that not all members have a designated place to call home, ECM meets members wherever they are. And it is intended to be high touch and done primarily through in-person interactions, as enhanced care management members are expected to be the most vulnerable in our community. And with an emphasis on building trust and rapport with members, it also incorporates providers with lived expertise to deliver this person-centered care. Next slide, please. All right. There are 7 core components of enhanced care management services that essentially define what providers must deliver to support high-need members with a person-centered and community-based approach. These core components include outreach and engagement, which is identifying and actively engaging eligible members, again, meeting them where they are, and many more like enhanced coordination of care, which entails a single lead care manager coordinating services, member and family supports, and so on. These again emphasize that each member's individual needs are nuanced and the delivery of services will be based on the member's preferences and needs. Next slide, please. All right. So now for community supports. Community supports are services provided to address members' health-related social needs, help them live healthier lives, and avoid higher, costlier levels of care. They are cost-effective and medically appropriate substitutes for covered Medi-Cal services or settings. They aim to tailor each member's unique needs rather than approach it with a one-size-fits-all lens. This personalized approach ensures all members receive the care that is right for them. There are currently 15 community supports and all are provided in Sacramento. We don't list them all here, but they are included in the appendix of the slides, which we have dropped in the chat, but will also be sent out to you all following today's meeting. I did want to touch on the housing-related community supports, what many might refer to as the housing trio, which includes housing transition and navigation, which helps individuals find housing and navigate the process of securing it. And we have housing deposit services, which are for permanent housing and help members with cost to move in and set up a basic household. And then we have housing tenancy and sustaining services, which help members stay housed and safe after they have moved in. So those are the housing trio supports, but there is a new housing related community support, which I'm sure many of you have already heard of. So if we could please go to the next slide. And that is none other than transitional rent. So transitional rent provides up to 6 months of rental assistance in interim and permanent settings for Medi-Cal members who are experiencing or at risk of homelessness and need support stabilizing their housing during critical life transitions. There are 3 criteria for eligibility, which include a Medi-Cal member having a clinical risk factor, a social risk factor, and falling under one of the transitioning populations, which does include those who are experiencing or at risk of homelessness. So transitional rent did officially launch at the beginning of this year, beginning with members with significant behavioral health needs. We are still in the first phase of transitional rent implementation, but it will expand to include other populations of focus over time. So there is certainly a lot more to come with transitional rent. But I will take a quick pause to see if there is anything that any of our managed care plans would like to add here. And if not, no worries, we can keep it moving. Next slide, please. All right, so now we are moving on to the community health worker benefit, which are preventative health services to prevent disease, disability, and other health conditions or progression to prolong life and promote physical and mental health. So this includes health education, health navigation, advocacy, violence prevention, and so on. It is intended for Medi-Cal members who might benefit from early intervention and culturally tailored support. It is important to note that it cannot be double-dipped with enhanced care management services to avoid duplication and ensure there is clear accountability for the coordination of care. It is also worth noting that the community health worker support is typically for more moderate needs, whereas enhanced care management is for higher acuity. Next slide, please. All right, we're going to move on to eligibility. Next slide, please. To be eligible for enhanced care management, Medi-Cal members must meet one of the listed populations of focus. For those experiencing homelessness, these definitions are based on the U.S. Department of Health and Human Services general definition of homelessness. Next slide, please. And here is a breakdown of eligibility criteria for enhanced care management, community supports, and the community health worker benefit. So, of course, individuals must be a Medi-Cal member enrolled in a managed care plan. And again, for enhanced care management, they must meet one of the populations of focus criteria. And for adults experiencing homelessness, they must have at least one complex medical need. For community supports, specifically for the housing trio, individuals must meet the HUD definition of homeless or at risk of homelessness. And I do want to add the caveat that for all of the other community supports, there are some slight nuances across eligibility criteria. I'm not going to get into that today, but there are some resources that, again, we will share out in the slides for you to reference if needed. And for the community health worker benefit, there is certainly a lot of information listed here. But to put it simply, individuals must have at least one health condition or risk factor and need help with health education, navigation, or accessing services. And this, I know this has certainly been a lot of information, but again, we will be having a lot of supporting materials embedded in the appendix. And again, friendly reminder to please drop any questions you might have in the Q&A. And I think I've spoken enough, so I am going to go ahead and pass it on to Shirley Lamb over at Transform Health for a policy update.
Thank you so much, Naomi, for setting the stage, and big thanks to Sacramento Steps Forward for putting this event together and for inviting Transform Health to present. I'm thrilled to be here to share the virtual stage with such amazing people and share just a bit of policy updates impacting the landscape of eligibility for Californians. But before that, let me introduce myself and the organization that I represent. Next slide, please. So my name is Shirley Lamb, and I'm a member of the Transform Health team as their Senior Program Associate. I work with an amazing team led by Rana Suleiman, who is the Senior Director of Transformation at Transform Health, and she oversees the Sacramento Providing Access and Transforming Health Initiative, better known as PATH, and we facilitate the Sacramento PATH Collaborative Planning and Implementation Group, better known as CPI. So next slide, please. So Transform Health is a nationally certified women and minority-led healthcare consulting firm with the mission to drive systems change to build and create healthy communities. Transform Health draws from multiple disciplines and perspectives to bring analytical rigor and innovation to healthcare policy solutions, delivery, workforce, and programming to advance quality of care and health outcomes for all. Next slide, please. So I just wanted to provide some grounding and some context for why we want to bring policy updates to you. These policy changes happen upstream and they can change downstream conditions, which can impact your daily work, your team, what's required. And so we really want to just equip you with that awareness so that to the extent possible, you can plan and organize proactively to respond and adjust to those policy changes. And then lastly, policies can have very cross-cutting impacts on the people that you serve. Policies don't exist in a vacuum. They interact with other policies. So we just want to, again, equip you with the understanding of those changes to help enhance meaning for your work and the people that you serve. So as a quick reminder, before we dive in, the policy updates that we're providing today, are current and accurate as of today. It can be a very, very fast moving landscape. So we want to give you the best information we can at this point in time. And then just finally, again, Transform Health is a politically neutral organization. So we're here to provide facts. We're not here to necessarily provide opinions or editorialize any of the policy updates that we provide. So next slide, please. So we'll start off today with some federal updates that impact Medicaid eligibility and enrollment. And just as a reminder, Medicaid is the term that is used federally. So California's version of Medicaid is known as Medi-Cal. Next slide, please. So the Reconciliation Bill, or better known as HR 1, or another term is the One Big Beautiful Act, was signed into law back on July 4th, 2025. So this slide shows the key provisions related to eligibility and enrollment for Medicaid. So again, that's the term that they use federally, but for California is going to be Medi-Cal. One of the new provisions is work requirements for adults in the Medi-Cal ages 19 through 64, with some exempted groups like parents or caregivers of individuals with disabilities or dependents ages 13 or younger. The effective date for this is going to be January 1st of 2027. So the states would have to be ready to go live by the end of December this year. The next two provisions touch on increased state responsibilities around eligibility and enrollment. So this includes more frequent eligibility and enrollment redeterminations. So this would be effective again, January 1st of 2027, which would also increase maintenance of enrollee records. The next provision narrows the definitions of immigrants who would qualify for Medi-Cal. So specifically, the bill does limit eligibility to certain lawfully present immigrants. It does eliminate the eligibility groups like refugees, asylees, and people admitted for humanitarian reasons. And that goes into effect this upcoming October 1st. So that's probably the first one that's coming up. The bill also postpones implementation of a few final rules until 2034. But in particular, one of the rules that it postpones addresses streamlining Medicaid eligibility and enrollment procedures. There is one more, but I'll skip that one. I don't think it's quite relevant to the audience of today, but collectively, these provisions will have impact on sort of the administrative lift and who is covered, and we could potentially see more Medi-Cal churn and changes in coverage due to the new administrative processes involved. Next slide, please. So the Department of Healthcare Services, or the acronym DHCS, released the HR 1 implementation plan back in February. And in the next couple of slides, I'll walk through with folks on what they'll need to know about their roles and what they could be. So next slide, please. So the federal implementation of HR 1 necessitates that DHCS adopt strategies to support eligible individuals in enrolling in and maintaining coverage while maintaining program integrity. So building on prior lessons learned from the state's implementation of Medi-Cal continuous coverage unwinding, DHCS will apply the following 5 key guiding principles. So the first one is to automate to protect coverage, which is maximizing the use of state, federal, and third-party data sources to confirm eligibility without burdening members and counties. They're aiming to reduce paperwork, streamline verifications, and safeguard coverage stability within federal statutory and regulatory parameters. The second one is to communicate with clarity. So leveraging existing and new communication channels and tools to implement outreach and education campaigns in all threshold languages designed to be culturally relevant, linguistically accurate, and written in plain language to build trust and help members, their families, and caregivers understand the changes and what actions are required of them. The third is to simplify the renewal experience. So they're hoping to modernize and streamline the Medi-Cal renewal process with clearer, member-friendly forms, first for the new adult group and later for all the other members, and with the 6-month renewal steps that would be helpful to make it easier to navigate, reduce confusion, and help members to stay enrolled and covered. The fourth is to educate and train those who serve Medi-Cal members by delivering comprehensive training on all HR1 provisions for county eligibility, providing clear policy guidance, practical tools, and ongoing technical assistance so that counties, plans, and providers can confidently support members and avoid error on member cases. DHCS will also be utilizing their coverage ambassadors with informative webinars, flyers, and communication toolkits to help them stay informed about Medi-Cal changes and help Medi-Cal members navigate these changes to stay covered. And the last one is to provide timely and transparent communication to members. Sharing information on HR1 changes early on through multiple channels that could be mailing, texting, even the old school, outbound phone calls. So members can build awareness, anticipate changes to their coverage, and have ample preparation time to meet new requirements. And because HR1 affects different types of members and phases over multiple dates, DHCS will be issuing a series of policy letters, provider bulletins, and guidance to ensure that Medi-Cal members, managed care plan and partners, or better known as MCPs, counties, providers, and stakeholders understand the applicable policies and procedures. Next slide, please. So within this guide, DHCS has laid out the various implementation partner roles across the Medi-Cal ecosystem. So on this slide, we'll focus on the role of providers. So hopefully folks that are on the call as attendees. Provider engagement for HR1 aims to help keep healthcare providers informed and prepared during the transition. So as mentioned in the prior slide, DHCS will issue bulletins, policy guidance, and technical assistance and trainings, and web updates to outline program changes and explain the updated workflows and system processes. DHCS recognizes that providers serve as trusted advisors to their members and is aiming that these efforts will ensure that providers have up-to-date information on program changes. So they may be prepared to assist patients who may need support gathering documentation for exemptions from work requirements. There is additional planned engagement with providers that include working with specific provider types that may be able to support identification of members exempted from HR1 reporting requirements. So this could include providers who specialize in behavioral health treatment, inpatient care, and those who work with individuals with intellectual and developmental disabilities, and those who were recently incarcerated. DHCS is also exploring the potential role of enhanced care management, or ECM providers, in conducting outreach to and supporting members with navigating new work requirements and increased eligibility renewals. Next slide, please. So on this slide, community health workers, we talked a little bit about that earlier. They were a service that was added as a Medi-Cal benefit back in 2022. They serve as trusted members of their communities, and DHCS recognizes that CHWs will be critical in the outreach and retention efforts for Medi-Cal members. This includes assisting members with navigating increased frequency of renewals and new work reporting requirements. DHCS considers these activities within the scope for CHWs and will provide additional guidance and technical assistance at a later date to support CHWs with carrying out these responsibilities. DHCS plans to partner with CHWs and providers that deliver CHW services to ensure that they have tools to educate their members on HR1 requirements and to support members on completing paperwork related to meeting work requirements and 6-month renewals. Next slide, please. And then, of course, the HCS also recognizes that local county offices play a very critical role in administering Medi-Cal eligibility and managing Medi-Cal cases on behalf of DHCS. So the state recognizes that the provisions in HR1 will significantly increase county workloads through work requirements, more frequent renewals that require manual verification and direct contact with members by the county, increased phone and foot traffic at county call centers and local offices, and they anticipate an increased churn in members gaining and losing coverage. So recognizing the expanded workload, in addition to the county's ongoing responsibilities for application adjudication and ongoing case management, DHCS will continue to work closely with the County Welfare Directors Association and counties to assess the additional impact through the state budget process. Next slide, please. So on this slide, DHCS has quite a couple of links that you can plug into. I'll make sure to drop them in the chat for everyone to access, but these are kind of some of the next steps for folks who want to stay engaged on what's to come from DHCS on HR1. These links are active, so when you receive the slide deck, I'm sure they're going to be dropped. But folks can stay engaged by subscribing to DHCS dedicated stakeholder listserv. You can read through the HR1 plan. I promise it's not that bad. It's like 30 pages or so. Watch the webinar that DHCS hosted a couple weeks ago, I'd say 4. And then you can also review the newly launched webpage that DHCS set up on the federal policy impacts on Medi-Cal. So next slide, please. And this is a call out. If you have any lingering questions about policy, please utilize the Q&A function to drop them in. Thanks for the time, and I'll pass it over to, I believe, Noni from Anthem to kick off the next section of this orientation on referral processes. Noni, take it away.
Thank you so much, Shirley. Hello, everyone. My name is Noni Plasichuk. Let's go to the next slide there. My name is Noni Plasichuk, and I'm a Regional Housing Strategy Program Manager with Anthem Blue Cross, and I am supporting the CalAIM implementation efforts. Very pleased to be joining you today in the shared learning space, and really pleased to share that I've been an Anthem team member for close to 4 years now, joining the team at the launch of the CalAIM initiative in 2022. So in my role, I focus primarily on housing-related activities and initiatives that support Medi-Cal members' journey toward achieving whole health. Let's go to the next slide. Okay, let's get into the referral pathway process. So when it comes to the referral pathway process for CalAIM services, one thing that I like to emphasize is that Anthem has a no wrong door approach. In fact, our no wrong door approach is really something that resonates across all of the health plans, as you'll hear throughout this orientation. And want to point out that there are many sources of referrals, including self-referrals or referrals from enhanced care managers and community support service providers. At Anthem, we believe that the majority of referrals really should be sourced from the community. And this may include referrals from community-based organizations, family support such as guardians, caregivers, clinics, law enforcement, school systems, and shelters, just to name a few. And at Anthem, we accept referrals through several platforms, including a secure email, which we've included a link to here, and through secure fax, and also through placing a phone call to Anthem's Customer Care Center. And there's even a referral platform. It's called Find Help, which some of you on this call may be familiar with, but for those who are not, I'm happy to really just share that it is a great source for non-contracted providers. So these are our community referral partners, non-contracted providers, and that we encourage our partners to utilize. So I'll be taking you through the steps to accessing Find Help platform for Anthem. Let's go to the next slide. Okay, so the main site for Find Help is accessed at anthembc.findhelp.com. What you'll do is create your login when prompted, type in the zip code when you're searching for resources. Let's go to the next slide. And what will come up next is a multitude of resources. So what you'll want to do is narrow down that search by typing either Enhanced Care Management or Anthem Blue Cross Community Supports. At this step, we do recommend bookmarking the links for future reference. Let's go to the next slide. So finally, what you'll do is you'll click on the Apply Here button to refer the member or client you're working with. And what will follow is an Anthem associate will receive the referral and will update the status accordingly. So one really great thing that I like to emphasize about using this platform as a community referral partner is that you'll be notified of the referral status through your dashboard. Let's go to the next slide. So here we have a summary on how to submit a referral, which includes links to the various pathways that were shared a little bit earlier. And so these pathways are member services, our phone number, Anthem's referral forms, secure email, secure fax, Find Help. And I also want to note that if you are a contracted provider, then you can actually refer through your provider portal availability. And so I'd also like to point out that in your copy of the slides that we're going to be sharing with you today, in the appendix section, I've also included some additional guidance on Anthem's Community Health Worker Program, which really is a valuable, as you heard earlier, it's a very valuable resource for collaboration with providers, primary care teams, and community agencies, and all in a goal to improve health outcomes for specific populations. And just noting that community health workers, they support members with health education, health navigation, non-licensed screenings and assessments, and individual supports and advocacy. And so that information for Anthem you'll find in the appendix section of your copy. Also want to include, it was touched on earlier about transitional rent. I wanted to share that there are some slides on Anthem's approach to the transitional rent benefit. And as you know, this is the newest community support benefit. So I just wanted to provide some additional guidance to this group on our approach. And for any questions on any of the information that I've shared with you today, I'd encourage you to just reach out. I'll be happy to drop my contact information in the chat for you. And just want to thank you all for listening. And now we'll transition over to Tiana Arbalou with HealthNet.
Thank you, Noni. I'm typing fast and furious in the Q&A section, so I appreciate you prompting me right now. Good morning, everyone. I am Tiana Arbulu. I'm a regional program manager with the HealthNet team, overseeing CalAIM implementation, as well as all of the population health management efforts in Sacramento County and some of our neighboring counties. Let's go ahead and go to the next slide. Thank you. So I have just a couple of quick high-level referral workflows for you all to help support, you all being a referral partner in the community with us. And before I dive in, just first and foremost, thank you so much for all of the work that you do for, in our community and for our shared community members. It is difficult work, oftentimes thankless work, but such important work. And we are grateful for you all being here today and showing up and helping our vulnerable neighbors. And so, what I thought would be helpful in putting together these slides, and then I know Noni also referenced, there's an appendix that you will receive with this deck that also has additional resources for you. We want to make the referral process as easy and effortless as possible. So here on this slide is HealthNet's ECM referral process. And you'll see that there's kind of different approaches that you can take. And the first, there's 5, I guess I should say specifically, approaches that you can take to refer a member for ECM services. That first option is something that would only be reserved for for organizations that are contracted providers with Health Net. So if you're a contracted provider with Health Net, you can refer directly through the provider portal. And it has that link right there that you can type in and send that referral straight away. But if you are not a contracted provider and are a community referral partner, I want to steer you towards the options 2 through 5. And so, the first step is verifying that member's eligibility. We have, and like I said, linked in some of the slides following, some really wonderful kind of one-page authorization guides for each one of the community supports. We also have a resource for, and I put it in the Q&A section as well, for a quick assessment on verifying ECM eligibility as well, that, I literally have like bookmarked on my computer. I think it's a great quick resource to refer to and encourage you all to do the same. So once you're able to verify members' eligibility, you would then, you could either make a referral through our Find Help platform. Noni just walked through that for Anthem. HealthNet uses the same platform. We just have a unique URL. So you can use the QR code to be linked there straight there for the HealthNet specific URL, and essentially make that referral in the same way that Noni just walked through. You'll want to make sure that you create an account first, of course, but all of the other resources and steps are outlined in the platform itself and mirror exactly what Noni just walked through. And another approach for making a referral is that provider directory. And essentially what that is a yellow pages of sorts that HealthNet publishes and posts on our provider website. You can also link directly to it through that URL, or I'm sorry, QR code rather. And essentially is a list of all of our contracted ECM providers by county and by population of focus. So you can look it up that way. And then you can also make a referral by calling member services. So the phone numbers are listed there. Those phone numbers are also listed on the back of our members, identify or member card. And you can call and speak to somebody directly to help place that referral. And then finally, there's the good old school fax style where you can fax in an ECM referral form to the fax number that is shown in that bubble below. So multiple ways to refer a member in. We really try and kind of take a no wrong door approach. So let's go ahead and go to the next slide, please. I will briefly walk through our community supports referral process. So again, this is a workflow similar to the previous slide, excuse me, but specific to community supports. So like, ECM, you'll want to verify members' eligibility for any of the given, 15 community supports. Like I said, we have linked resources for you to check that eligibility quickly with our one-page cheat sheets, if you will. And once that's verified, you'll want to complete that authorization guide and then make the referral through Find Help or the provider directory. So Find Help is the preferred platform to do so, just because it's kind of a one-stop shop. It's all, housed in a central location and easy to track. So you would create your account if you haven't already, complete that CalAIM assessment form, and then submit that referral request. And then likewise, similar to what I walked through on the previous slide, you can also use our provider directory to look up our list of providers there. And the thing I didn't say in the last, when I was reviewing the last slide, something that is kind of cool about the provider directory is it is broken out by zip code as well. So it's not just by county, but by zip code. So you can find kind of the closest contracted provider based on where your member is located, and call and make the referral that way. Next slide, please. And this is just, these are the authorization guides and referral forms that I was referencing. So in that orange sunburst at the bottom of the page, that is a link to all of these resources here. Again, these are like quick 1 to 2 page documents where you can quickly verify a member's eligibility for any one of those community support services, and then those go ahead and submit those referral forms. So everything, I think this slide doesn't have transitional rent on there, but if you use the live link, transitional rent will also be on there for your reference as well. And so that is it for me. I will transition over to, I think it's Jillian that's up next. I'm not quite sure. It might be Debbie or Asya. No, it's Jillian. Okay, Jillian, go ahead. Thank you very much.
Yeah, you're right on it. Yeah, thank you so much. Hi, my name is Jillian, and I'm here today from Kaiser Permanente, and I'll also be going over our referral process for enhanced care management, community supports, and community health workers. Thank you for the applause. I love that. Yeah, it is, you're a large group today, so all the applause is appreciated in these transitions. But we also do have a slight nuance that will have a little bit of extra today for the Kaiser Permanente section, which is our network lead entity model and how that may impact the referral process or kind of our processing timeline. So excited to also get into that today and answer any questions later if they come up. So if we go ahead to the next slide. This is an overview of our case management and additional benefits within the Kaiser Permanente sphere, though a lot of this is similar to the other managed care plans on the call. So you'll see everything in purple is what we do outside of house, and everything in blue is what we do inside of house. So we do basic population health management with KP staff. That's handled by KP staff. Complex care management is a type of care management we also do in-house here at Kaiser Permanente. But as DHCS requires, everything in purple, we contract out with external organizations to handle those types of services. So that is, again, enhanced care management, community health workers, and community supports. So if we go to the next slide. We contract for all 3 of those through what's called a network lead entity. And this helps us get comprehensive network coverage over our footprint. So we are one of the larger managed care plans in California, and we cover 32 counties here within the state. And so using this network lead entity models is one of the tools we use to ensure network coverage or network adequacy across our geographic footprint. So it's one of the ways we find comprehensive network coverage along all of those different counties and between our different populations of focus and community support types. So if we go to the next slide. We have 3 different network lead entities in California, but we have 2 here in Sacramento. So I want us to focus on the left-hand side here. It's going to be Independent Living Systems, which primarily handles adults, and then Full Circle Health Network, which primarily handles youth and families. So there are a couple other nuances there, but that's kind of how I generally sort the 2 or differentiate the 2. If we go to the next slide. So what does this mean for our referral process? What does this mean? So for our referral process, it's not directly impacted in the first initial stage for most folks. So we have 3 different referral form types here at Kaiser Permanente. And of course, I'm also not speaking about the amazing Sacramento referral form here that we have across our managed care plans. But if you did want to do the United one enhanced care management form, and you did want to do one of our Kaiser Permanente forms, or for example, you wanted to do a referral for housing insecurities, or you wanted to do a referral form for medically tailored meals. We have 3 different types of referral forms. So the first bucket is enhanced care management, complex care management, and community health workers. So kind of our different types of care management we have bucketed all into our first form. And our second form is all housing insecurity. So we actually have 7 of the community supports, I believe, on this form. So that's housing navigation, housing tenancy, housing deposits, as well as recuperative care, short-term post-hospitalization housing, day habilitation, and now transitional rent is also on this referral form. Then we have the keeping members in at home and chronic conditions. So I essentially think of that as everything else, whether that be medically tailored meals, as mediation, a lot of other really good supports can be found in that final referral form. And if we go to the next slide. So submitting referrals. So the primary way we get referrals from external organizations, so those in the field interacting with folks, which I saw is a lot of people on today's call, right? It would be, if you're with the member, I would recommend calling. So if you're physically with that member and you think it might be easier, or say we have a follow-up question on our care coordination team, calling the phone number can actually be helpful because we're able to get that follow-up question answered in real time, again, with the caveat that would have to be also within the business hours of that phone line operation. But the most popular that we see is via email, via secure email. So we have editable PDFs, similar to our other managed care plan partners. So you'd fill those out and then send those via secure email to our care coordination email boxes. And of course, since we're in Sacramento, we would be following the Northern California counties kind of column here. So if we go to the next slide. If you did have questions about our network lead entity model and you had interest in speaking to one of them more directly, I have also included the Independent Living Systems contact information as well as the first Full Circle Health Network contact information. They do have different kind of office hours depending on the type of support you are looking for. If you wanted contact information for independent living systems, the first step would be sending an email to the email at the bottom of their column. And then I believe that this deck, the hyperlinks should be active. So for Full Circle Health Network, those links actually will be usable as well, but you can also reach out at that email as well. And if we go to the next slide. Here is kind of how that shakes out. Again, the network lead entity model is a little confusing. I know we're a little unique in that, though some things are changing in the landscape, but this is kind of how we at Kaiser Permanente have our ECM referral process breakdown, just to know what the expectations are to getting that referral processed and what you can kind of align expectations within your organization, but then also with the member to ensure they know kind of the timeline of follow-up from, initial referral to the ECM engagement that happens, within the, first referral form filled out all the way to the first interaction with that ECM case manager. And if we go to the next slide. I've also included some resource links, so this is kind of more broad, and I hope these are helpful. But for example, I've included some continuity of care information, our member handbook, we have a call center, and also our transportation services, which is another popular benefit for this population. So thank you so much for having me today, and I'm going to turn it over to my next managed care colleague. Thank you.
Hey, everyone. If we go to the next slide, mine is going to be pretty simple, I think, compared to everybody else's. We're just have one slide here, and just to reference how to make referrals to both enhanced care management and community supports. Just to introduce myself, I'm Ossie Anderson. I'm our Director of Special Populations, so I oversee enhanced care management, community supports, as well as our housing and homelessness programs and our incentive programs under CalAIM. So our referral process is pretty simple. We have all of our referral forms available at the live link that you see here, the first link there where it says molinahealthcare.com that ends with FUF. That's frequently used forms. So we have our ECM forms. We have an adult version of the referral form as well as a youth. And then we have 13 of our referral forms for community supports, individualized for each individual community supports. For ECM, all of those referrals should be emailed in to MHC_ECM referrals at molinahealthcare.com. There is an underscore there in that first email address. So just making sure that you have that. And then we can also answer any additional questions from the ECM team at MHC_ECM at molinahealthcare.com. But basically, all you need to do to send in an ECM referral and get a member referred into ECM would be to submit that referral form to that email address. For community supports, we accept referrals via fax. So each of the referral forms that's available on that website under frequently used forms will have a fax number associated with it. It is the same fax number for everybody, but basically you just fax the referral form to the number on the referral form. If you have any questions, you can also reach out to the community supports team. I would not submit referrals there, but just email MHC_CS at molinahealthcare.com. And then for transitional rent inquiries, we do not have a referral form live on our website for transitional rent. And the reason behind that is because it is really a narrow set of folks that are eligible for transitional rent at this time. And we want to make sure that we're not submitting referrals for folks that are not really appropriate for the benefit. So if you have a question, if you believe that you are working with a member who's probably eligible for transitional rent, we ask that you go ahead and submit an inquiry to MHC_transitional at molinahealthcare.com. And if we, agree that it looks like the member would be eligible, we'll send you an inquiry pre-screening form back in order to fill that out and get that member screened for eligibility. And then we would turn that into a referral. And I think that's it for me. I will hand it back to Transform.
Thank you, Asia. So hi again, folks. Shirley Lamb with Transform Health, and I'll be taking just a bit more time with you all to walk through the Sacramento Enhanced Care Management referral forms. So next slide, please. As it was alluded to earlier from Jillian and all of our managed care plans, one of the things that we heard from a variety of our stakeholders and our collaborative members was, the need to expedite and streamline the referral processes for both adult and children and youth populations of folks in Sacramento County. So the Transform Health team set out with our 4 amazing managed care plan partners, Anthem, HealthNet, Kaiser Permanente, and Molina, and of course, our county representatives, the County of Sacramento Public Health, to develop a standardized referral form for both populations of focus that would be accepted by each of the 4 managed care plans. And voila, we were able to successfully create these forms. So next slide, please. One of the great resources here that the Sacramento Path Collaborative co-created with our managed care plan partners was the ECM referral forms for adults. As we mentioned before, this form is accepted by all of the managed care plans in Sacramento. A printable PDF version of this form is housed on the Sacramento Path SharePoint site. And again, a huge thanks to all of our managed care plan partners for their collaborative efforts on this project. We'll be able to email out a refillable version with all meeting materials by the end of this week. And again, the printable PDF version is housed on the Path SharePoint site. I'll make sure to drop in my email so that folks who would like access to it, they can directly email me and I can make sure you're registered through our SharePoint site. So next slide, please. And again, in similar fashion, we also created an ECM referral form for children and youth. So again, amazing collaborative work across our managed care plans to pull this together. This was one of the results of Q3 of 2025. So again, this printable PDF version is also housed on our Sacramento Path SharePoint site. But should anyone have any questions or would like access to them, I'm going to drop in my email in the chat for everyone so you can directly message me and I'll make sure that you're added onto our SharePoint site. But with that, I will pass it back over to the Sacramento Steps Forward team for any additional remarks.
Thank you so much, Shirley. I appreciate you passing it back over. clearly, that was a lot of information. That was a fantastic wealth of information. So the next couple of screens really you will have in the slide deck available to you if you haven't already downloaded it. Contact information, of course, for Sacramento Steps Forward and Anthem, HealthNet, Kaiser, and Transform. I feel like Molina may be on another slide as well. And if it's not, then we will add it. As all of the fantastic panelists shared with you, we have a wealth of resources. These links will be active in your slides. And from this point on, I believe we are complete in all of our materials. So now we get to move through some great Q&A together. I will stop sharing our screen. If you do not have any questions, this is the time to say thank you and have a fantastic day. I will always invite you to please complete the exit survey so that we can help. Actually, the surveys help us serve you a little bit better. So please complete that survey on your exit. We appreciate you. And again, we've got another 30 minutes here to go through quite a few of our Q&A, so stick around for that. You can also learn more about our trainings on our website. Look at the Provider Hub. And again, I thank you. Naomi, I'm going to turn it over to you.
Yeah, thanks, Jody. And thank you so much to all of our presenters today. And of course, for all of you for submitting your questions. I think it's best we can go ahead and just get started with raised hands. So I see Carolina Wade has their hand raised. If you want to go ahead and come off of mute. Let me see. All right, Carolina.
I like that sound. Oh, sorry.
Hi, Carolina.
Sorry, that was an accident. My bad.
No worries. All right. I see Tanaya Woods. All right, Tanaya, you have the option to unmute, so go ahead.
I just had a question. That ECM referral form, is that just for ECM or is that for community supports as well?
If we're talking about the joint managed care plan referral form, that is specifically for enhanced care management.
Okay, thank you.
Of course. All right, now I see Denise. Go ahead, Denise.
Hello, I have a question. I work for parole, and a lot of times when I make referrals for the ECM referrals, and they're unable to contact the client because a lot of times our folks, they move a lot, they lose their phones for various reasons. And so can I accept the managed care plans from the various, whether it's Kaiser, Molina, or HealthNet, contact the referral source? Because sometimes by the time we make the referral, the client may have another phone number or contact information, because I've had situations where I've made a referral, they can't find a client and then they close it. And so I just want to know, how can we circumvent that so we can make sure clients are connected to ECM services and supports?
I know this is, oh, go ahead, Jillian.
Yeah, I can jump on this. So first, I just want to say thank you for making those referrals. Our most successful referrals are those that come directly from the community. So thank you for being one of the referral partners that we have out there, really pushing those through. And I will also say that I'm not surprised to hear you say that. This is one of the most challenging things that we work through as health plans, is addressing how to contact folks post that referral form being submitted. So a few things that either DHCS or we internally have tried to do to solve this include oh goodness, what's it called? It's the streamline authorization for enhanced care management. So essentially, if you do happen to be contracted with that health plan for enhanced care management, you can start services for that member that same day. And so we can talk a little bit more about that, but that same day linkage is really important. And I appreciate DHCS's attempt to kind of, acknowledge that this is something that we are all struggling with and try to find a workaround for us. Additionally, we here at Kaiser Permanente have added extra contact information fields on our referral forms so that even if that first referral contact doesn't work, we do have a second one and maybe even a third one. So we're working on it as well, but I appreciate you elevating that is something we are also struggling with.
Thanks, Jillian. All right. And I do want to add, we'll get through the raised hands first, just in case we aren't able to get to the remaining questions in the Q&A. At least we have those to answer and share following today's session. So up next, we have Mika Moreno. All right, Mika, you are able to unmute yourself. Go ahead.
Hello.
Hi.
Hi. So my question is, it's kind of piggybacking off of the parole question for ECM. So working with the level four population, sometimes there's barriers with, staying in consistent communication with members once like a referral is submitted. So I guess my question is, would becoming a contracted provider with these providers, would that be a solution to us being able to communicate with Molina or Kaiser on their behalf once those referrals are submitted?
Do any of our managed care plans have any answer to that?
Thank you for the question, Mika. I think, a member, so if you're working with a member for services and you want to be able to speak to either the contracted provider helping provide the services or to the managed care plan on the member's behalf, that's approval that the member has to give. So I think, as long as and I think somebody lifted, I can't remember who, if you're working with them and you have them next to you directly, they can give that verbal auth of saying, yes, you can speak to Mika on my behalf for this service. But that would be the kind of the qualifier there, is that there needs to be member approval because of, protected health information, HIPAA requirements and things of that nature. But invite my plan partners to weigh in if they have additional information or thoughts to add.
No, I would agree with you, Tiana. It's really, we do need to make sure that we have member consents in order to be able to speak with you regarding that member. So as long as we have that, then it shouldn't be an issue and working to be able to do care coordination, but we do need to be able to have that to be able to share protected health information.
Okay, so my next question then would be, is there like an ROI, like a standard ROI that we can submit when we're submitting these referrals via email or, however we're doing it, so that way we can continue the communication? If we're not calling over the phone, like say we're submitting the referral via email.
I don't know if I have I don't think that our team has a standard ROI. I'd have to follow up, and that's something I'd be happy, like when we package all of our follow-up materials, to call that out. I'd want to follow up with our some internal teams to check on kind of like what is permissible in terms of giving that, member giving that consent. But I don't know if other plans have kind of a different approach or a standardized approach that they can share.
Yeah, Noni with Anthem. Thank you, Mika, for the question. So no, for the referral partners, Anthem doesn't have a standard ROI to submit with the referral. One thing I do want to call out, though, something that we had shared a little earlier, if you use, I mean, just, considering maybe the platform as to how you submit the referral, if you choose to go through, say, Find Help, that might provide some relief because you'll be able to at least see the status. Has that person been connected at least to a provider? Given you won't be able to see like the ongoing communication between that member and the service provider. So I know that that could be a concern there. But what maybe one solution to consider is when you submit that initial referral, right? And you are speaking with that member, getting their consent on the spot, and even making sure that that's spelled out on the referral itself. That could be a helpful tool, like the member is giving permission to get in contact with your initial referral partner. Maybe just communicating that from the gate could be helpful. But no, there's no standard ROI. Something to look into, though.
Thank you, Noni. Naomi, there are still quite a few questions in the Q&A. I'm going to elevate and move through. Thank you, everyone who is still with us. We have 16 open questions at the moment. The first one I'm going to elevate is from Gabrielle. I have been referring unhoused families to CalAIM community support and ECM services for the past 3 years. I've seen the waiting time to get assigned to a case manager from 2 weeks to 6 months. But for the past year, I've been sending referrals through the findhelp.org, but my clients have been getting rejected from CS and ECM services through their MCPs due to capacity. I'm not trained in CAS or HMIS, so I'm limited to referring clients to housing navigation. Because of these challenges, I have 2 questions. Once referred, how likely are clients able to get assigned to an ECMCS provider? If rejected through their MCP, are there other organizations who provide CalAIM services that will be able to provide housing navigation or medical coordination? That was a lot.
That was a lot, but I'm happy to definitely provide some insight there. So as long as the person is meeting the criteria for the services, then they will be assigned a provider as long as they're meeting that criteria. It may now the length of time, I will say, sometimes, just given capacity, if there's just a flood of referrals that are coming through, it may take time for example, Anthem's clinical team to really kind of get through those referrals to get your member assigned to a provider. But as long as they're meeting the criteria, and as long as, if there is any documentation that is spelled out on the referral, for example, and that should be submitted with that member's referral, as long as that's being responded to and all the ducks are in a row, that member should, be getting connected. Sometimes it does take time, and it takes longer than what we would hope our standard turnaround time. It can take longer. One thing I do want to point out to your second question is yes, and I think the purpose of having these wonderful orientations too is to connect and to see who else is on the call, and maybe even on our end, we're happy to share who are our contracted providers. Okay, if you're connected with a contracted provider, then there's another referral path. You're reaching out to the contracted providers in your community to assist that member. Maybe that moves it along faster.
Thank you, Noni. I appreciate that thoughtful response. Naomi, is this a good time to talk about the CalAIM Learning Collaborative because I feel like that next conversation that we have after this orientation actually leads into the value and importance of our CAS and HMIS systems so that there are more opportunities for referrals and connecting with other providers.
Yeah, absolutely. So I do think first and foremost that that audience, it might be a little bit more, we might be a little bit more specific with who's in that conversation. But yes, we will be hosting a three-part series, which we are offering as a learning collaborative for CalAIM providers in Sacramento. And give me just a moment. I'm finding just a little bit of information that I can share there. Okay. And yes, okay. So this is a three-part series, and this is intended for providers to better understand the purpose and benefit of being involved in the coordinated access system and utilizing the homeless management information system. So it's really more of a collaborative space to allow providers to, discuss their experiences in real time and to kind of collaboratively figure out how to I guess better improve workflows when it comes to, being involved in coordinated entry and using the HMIS. So certainly there's more to come there, but yes, happy to share that.
Thank you so much. There's still a handful of questions. Naomi, I'm going to go on mute and just answer what I can. Yeah.
Yeah, thanks, Jody. So I do just want to get through the raised hands. So I do see Keith has a hand up. So Keith, go ahead and come off mute.
Hello, thank you. Just had a quick question on just pointing me in the right direction. We provide housing and navigation services for the justice impacted population primarily, other populations as well. What I'm trying to understand and wrap my head around is where to go to become a contracted provider for ECM or CS services.
Thank you, Keith. If you are interested in becoming a contracted provider, you can reach out to any one of the managed care plan reps that's on the call today, and we can work with you to provide you our provider interest forms. And essentially, that's kind of the initial step in becoming a contracted provider. Just to speak briefly about HealthNet's process is, we have to assess our existing network of contracted providers and the services that are being offered that you're interested in offering to, make sure we are not we don't want to over contract. We're being very intentional and right sizing our network to make sure that the providers that we're contracted with are getting appropriate volumes of members to serve. And, if we do identify that there is a need to increase our provider network for any given community support or enhanced care management, enhanced care, ECM population of focus, then we would, after you submit that provider interest form, we would invite you to submit an application as well. So that's kind of briefly what the process looks like. I would say, generally speaking, we share one another's application materials as well, just to reduce that administrative burden in the contracting process, should you move forward along that way. But I will pause to let other plan partners kind of share a little bit about their process as well.
Well, thank you, Tiana.
Oh, go ahead, Noni.
I was just going to thank Tiana, similar process. And so yes, just starting out with that letter of interest, that will be your initial first step. And of course, we would assess from there. And I'll go ahead and drop a link to where you can access Anthem's letter of interest. I'll put that in the chat for you.
And I will echo what both Tiana and Noni said for Melina. It is, we would accept a letter of interest at this time. I do want to flag, kind of as Tiana said, we are right sizing our network. We don't want to over contract. So as a result, at least for Melina, we are not particularly open to new contracts at this time as we're doing a full assessment of our network. We don't want to contract with folks that we are unable to support with members. Because we do have sufficient capacity at this point.
All right. Thank you all so much for sharing, and thank you for your question, Keith. And I do see that was one of our questions in the Q&A, so glad that we got that taken care of. All right. I'm going to go through pull a question from the Q&A, and then we'll go back to a raised hand. I think there was one question that I think would be helpful with answering live. Where was it? Okay. So we have a provider who is currently in the contracting process with the managed care plans, and they are seeing a high immediate need for short-term support. What are the best pathways to help these community members right now to ensure they don't fall through the cracks while formal billing is being finalized? Do any of our MCP partners want to share?
Yes, absolutely. I did see Naeem. Was that Naeem's comment? Hello,
Yes.
Naeem. I'm so glad that you could join today, and I really appreciate the partnership we've had thus far. I would say just, honestly, just joining forums where there are other providers who, are perhaps already serving some members, and maybe they are in need of a site, a place to house the members. Connect with them, because I think one of your goals is to ensure that the news is spread that you do have available units or available housing units. It really becomes about the access to those units. So I would keep doing what while you're in the contracting process. Contracting takes time, but while you're in the process, and knowing that you have available units, I would continue to do what you're doing is spread the word by all means. I think other providers who are really trying to navigate and house their members would love to know about the availability of your sites and the units.
Thank you, Noni. All right, and I know we're getting close to time, so maybe we'll allow for one or two more questions. And I do see Alicia here with your raised hand. Hi, Alicia. Go ahead and
Hi,
ask
Naomi.
your question.
Can you hear me?
Yes.
Hi. Okay. So I was on the last CalAIMS meeting, and in that CalAIMS meeting, I was told about the housing deposit and how each care provider dealt with the housing deposit. And we have a rapid rehousing program. So a lot of our clients that we have housed, we have referred them back to their healthcare plan, whether it's Anthem, HealthNet, Kaiser, Molina. We've referred them back there and told them to call the numbers that were on the pamphlet we got from last time, and to ask for the housing deposit, because I did make sure that everybody can help with furniture in that housing deposit. And the feedback that we've gotten from our clients is that they've had a really difficult time, if denied, almost every single time, getting that housing deposit, like working through that whole system and doing the process. They get through the process, they get to the broker, they get that far. Some of them don't have the income. I guess there's like an income that they have to have in order to get the housing deposit, just even with the furniture help. And then the ones that we've got through with the housing, with the income, they are also fighting a lot of barriers that it's not as easy as I guess I made it sound, from what I was told. So I'm just trying to find out like how is there something else that I need to be telling them, or is there more advice you guys can give me from the healthcare plans on what to do when it comes to these situations to better serve my clients?
Thank you for lifting this up, Alicia. I appreciate that. And I apologize for the difficulty that some of your clients are having with accessing that benefit. The one thing that I guess I just would want to make sure of is, and I know that the MCPs worked with Transform Health to put together kind of a cheat sheet of housing related services, including guidance on the housing deposits. And I'm not sure if that's a resource that you have available to you. If not, we can make sure that we send that in the post-meeting follow-up materials. I'll also pop a link in the chat for HealthNet's authorization guide. I think it's a good cheat sheet. The one thing that I would say, there's a total lifetime maximum to those housing deposits. And there's a range between a couple $1,000s amongst the plans in what is offered.
Mhm.
And then there is also some threshold limits for the what the various household items are that the member is trying to receive. So, making sure that a member is not spending $2,000 on a new TV, when beds and couches and a kitchen table are needed. So there are some qualifiers in what is actually authorized. It's not, a blank check for $6,000 to go buy what you need. And if it's helpful, like I said, I can put some our authorization guide in the chat. But yeah, I think that it's hard to know, right, without understanding like each instance that you're referring to understand what those denials are. But just wanted to kind of share the general frameworks of how that benefit works. But I'll pause and let plan partners weigh in if they have anything else to add as well.
Thank you.
Mhm.
Say for Melina, for housing deposits, similar to Tiana, we are focused on making sure that the housing deposits are being used first and foremost as a deposit for the house. So we really would not want to see that it's primarily being used for household goods. We do allow, of course, household goods to be purchased, but we do have some limitations around it. It really it needs to be, in accordance with the policy guide, the minimum that's really needed for the member to have a safe move into their home. So if the member needs a bed, the member needs, basic pots and pans, those kinds of things. It doesn't need to be the lowest cost option, and it needs to be appropriate for that member. We've seen requests for things like a PlayStation 5. And that we don't think is a good use of resources. Realistically, that's not good for a safe move-in for anyone. So there is, we do have some kind of guidelines around that. We put some dollar amounts around, based on what we kind of we're seeing as appropriate averages for some of those household goods. And we do ask that not more than half of the total deposit amount be used towards household goods. We really want it to be focused first and foremost on deposits. And again, the reasoning behind that is that these are in lieu of services. These are services that we are offering as a lower cost option to something else. And it also means that we're not reimbursed for these services, not directly. And as a result, every time we spend money on something like a big screen TV or a PS5, that's somebody else's housing deposit that we can't pay. So we really do want to make sure that we are prioritizing putting these funds where it's most appropriate. And for us, we really feel that that is towards the deposit itself, which is the intent and spirit of the community support itself. And then limiting those household goods to really the things that are needed for a safe move-in.
Thank you so much, Tiana and Asia, for answering, and thank you for your question, Alicia. I do think we are at time, so we're going to go ahead and wrap it up, and I will pass it on to you, Jody.
Thank you so much. There are still a handful of questions. What we usually do when we still have unanswered questions is we collect them, send them out to our panelists for answer, and we'll include them in our Q&A that will be sent out to all of you that have shared your time with us on this webinar. Thank you again to each panelist. I know how precious our time is, so thank you for sharing yours and all your wisdom and insight. I will also remind everyone to please visit our website to learn more about provider trainings and collaborative offerings like this. And that is it. Naomi, is there anything else that you want to plug or share before we conclude our time?
No, I think we're good to go. Just thank you again to all of our panelists and, for presenting and bringing your wealth of information. And thank you to all of you for all you do for our community.
All right. And for all the providers, thank you for what you do. Have a wonderful time, a wonderful day, and we'll see you next time. Thank you.
Thanks, everyone.